The following presentation is on Sacubitril Valsartan, the combined neprilysin inhibitor and angiotensin receptor blocker that was recently approved for the management of heart failure with reduced ejection fraction, and really posing the question, should we be reshuffling the deck in our management of this patient population? So I have nothing to disclose as it relates to this presentation. I think a good place to start is to first look at the current paradigm for the management of patients with heart failure with reduced ejection fraction. This comes from the 2013 guidelines. Now, as many of you already know, the backbone of the treatment of this patient population is ACE inhibitors or ARBs plus beta blockers, and a select number of those patients will also be eligible for ICD placement plus or minus cardiac resynchronization therapy or CRT. Now, beyond that, the option of additional therapy is based on very patient-specific characteristics. For those that remain symptomatic with volume overload, loop diuretics are our drugs of choice. Those only improve symptoms and not long-term morbidity and mortality. For patients who are African American who remain persistently symptomatic, the therapy to add is long-acting nitrates combined with hydralazine because of additional reductions in morbidity and mortality. And then for any patient that remains symptomatic and has an adequate creatinine clearance, so greater than 30 mils per minute, and a potassium less than 5.0, you can consider the addition of an aldosterone antagonist such as spironolactone or eplerenone. Now, the reason that we select these therapies is that they've been associated with substantial improvements in heart failure outcomes, including all-cause mortality. You can see here in this graph the number needed to treat for all-cause mortality with a number of the landmark trials listed there along the bottom axis. So ACE inhibitors, beta blockers, aldosterone antagonists, nitrates, hydralazine, and CRT. And you can see here that really for most of these therapies, you need less than 40 patients to see an improvement in mortality. But despite this diverse armamentarium, we still have a lot of work to go. So you can see here in this first graph, this is a representation of the incidence of heart failure. We have discharges in millions and sort of the years there on the bottom axis. You can see that with the exception of the last several years, we've had a steady increase in the number of patients who've been discharged with a new diagnosis for heart failure. You see very similar trends when you look at prevalence. So by the time men reach the age of 60, about 1 in 10 will have heart failure, about 1 in 20 women will have heart failure, and then by the time they reach the age of 80, both men and women, greater than 1 in 10 will have heart failure. So we definitely have room to go. Now, the next, as we sort of shift gears here to talk about sacubitril valsartan specifically, I'd like to begin by talking about how it impacts the heart failure syndrome. So many of you are already familiar with the renin-angiotensin-aldosterone system and its role in heart failure. When peripheral tissues sense a decrease in cardiac output, they release a number of neurohormonal mediators, one of which is angiotensinogen. It's eventually converted to angiotensin II, one of the body's most potent vasoconstrictors. It activates the AT1 receptor, leading to a variety of pathologic effects in heart failure, increases in vasoconstriction, sympathetic tone, aldosterone release, and because of those effects in the long term, some of these remodeling effects such as cardiac fibrosis and ventricular hypertrophy. There's also a countervailing system called the natriuretic peptide system, which seeks to improve some of these pathologic effects of the RAS system. So in response to stretch, myocardial stretch, pro-BNP or pro-brain natriuretic peptide is released. It's then cleaved into NT-proBNP and BNP. And BNP has a number of salutary effects on the cardiovascular system. So it decreases vasoconstriction, decreases sympathetic tone. It also decreases aldosterone release, which can improve some of those long-term remodeling effects, and it decreases the amount of sodium and water reabsorption, so leading to improvements in natriuresis and diuresis. Now, the problem is that the neprilysin enzyme, abbreviated here as NEP, breaks down BNP into inactive fragments, preventing it from having these beneficial effects. Now, let's look at the use of LCZ696, which is an abbreviation for Sacubitril Valsartan. It's a combination of these two drugs. Valsartan, as many of you already know, is an angiotensin receptor blocker. It blocks the effects of angiotensin II on the AT1 receptor. Sacubitril is the novel part of this molecule. It is a neprilysin inhibitor. It breaks down or prevents the breakdown of BNP, allowing it to have those beneficial effects on the cardiovascular system. Now, this isn't the first time that we've looked at neprilysin inhibitors. In the early 2000s, there was a compound called omapatrilat, which was a combination of an ACE inhibitor and a neprilysin inhibitor. But when compared to enalapril in the OCTAVE trial, you can see here in the composite endpoint of death or hospitalization for heart failure, there was no improvement there's no improvement with omapatrilat. Similarly, when you look at death alone, there was no benefit with omapatrilat. Now, in another trial, there was a substantial number of patients who developed angioedema, and it was thought that this was an unacceptable rate. And this was due to the well-known risk associated with ACE inhibitors of causing angioedema, but because neprilysin is also responsible for the breakdown of bradykinin, it's likely that the neprilysin inhibitor plus the ACE inhibitor had sort of a synergistic increase in bradykinin concentrations, leading to that unacceptable rate of angioedema. So that's really what led researchers to instead look at a combination of neprilysin inhibition and angiotensin receptor blockers rather than ACE inhibitors. So that brings us to the Paradigm HF trial. I want to first look at the inclusion-exclusion criteria for the trial, starting first with inclusions, which were fairly straightforward. These were adult patients who had symptomatic heart failure, so classes 2 through 4. It was a reduced ejection fraction population, so they had EFs of 40% or less. You were required to have a BNP of greater than 150 or a BNP that was greater than 100 and a hospitalization for heart failure in the prior 12 months. Now, some institutions use NT-proBNP, and so I've listed there in the footnote what those cutoffs were. Essentially, it was 4 times that of the BNP cutoffs. And then you had to be on stable doses of ACE inhibitors or ARBs plus a beta blocker for greater than 4 weeks. Now, I've just listed some of the exclusion criteria, and mainly those that I think impact the generalizability of these results. So you were excluded if you had symptomatic hypotension or a systolic blood pressure of less than 100. Patients with significant renal impairment, that is a glomerular filtration rate of less than 30, were excluded. Patients who were hyperkalemic at baseline. If patients had a prior intolerance to the target dose of an ACE inhibitor or an ARB, or if they had a known history of angioedema. So essentially excluding those patients who are at highest risks for adverse effects with the new drug therapy. Now, when it came to the overall design of the trial, after patients were screened, they then underwent a 2-phase run-in period. So the first phase was an enalapril run-in where they were started at enalapril 10 milligrams twice daily, or they could initially be started at 5 BID and then up-titrated to 10 twice daily. There was then a brief washout period, and then all patients went into an LCZ 696 run-in period where they were initially started on 100 milligrams twice daily and then up-titrated to 200 milligrams twice daily. For all patients that made it through the 2 run-in periods, they were then randomized 1-to-1 to either LCZ 696 or enalapril 10 milligrams twice daily, which was considered the standard of care for this particular trial. Now, when you look at the patients who were excluded from after this run-in period, it was fairly similar between the 2 groups. About 1 in 10 patients had to be excluded because of an issue in the run-in phase. Now, about half of those discontinuations were due to an adverse event, a little under 6% in each group, driven largely by hypotension. You can see here in this table there were a variety of other miscellaneous issues that also led to those study discontinuations. Now, for those patients that did get enrolled in the trial, you can see some of the pertinent baseline characteristics here. So they were all a little over 60. The vast majority of patients were male. And a really important piece to point out here is the lack of diversity for the population. So they were primarily Caucasians, they were white and Asian. Very few black patients enrolled in the trial, about 5% in each group. They had fairly robust blood pressures, essentially normal, and a normal creatinine. And most of these patients had New York Heart Association functional class 2 and 3, so greater than 90% of the population. And then finally, I want to point out here at the bottom of the table, about 2/3 had been hospitalized for heart failure in the last year. Now, also some important things to point out for the baseline medication use. So good use of beta blockers at baseline, but importantly, only about 50% of patients were taking an aldosterone antagonist at this time, despite the fact that the vast majority of the patients enrolled in this trial would have been eligible for one. A very similar critique, you can see there for the implantable cardioverter defibrillator use. Again, the vast majority of patients in this trial would have been eligible for that intervention, but only about 15% in each group had that. And that'll be important when it comes to one of the outcomes that I'll point out a little bit later. Now, looking at the primary endpoint, you can see here in tabular format, LCZ 696 did lead to a reduction in the primary endpoint, which was a combination of death from cardiovascular causes or first hospitalization for heart failure. And also, when you look at the individual components of that composite endpoint, they were also both improved with LCZ 696. Now, visually, you can see here in the primary composite endpoint that the differences started to emerge at about 6 months into therapy, and then they persisted for the duration of the trial. And then there was a number needed to treat of about 22. And when you look at death alone, you see a very similar trend. So at about 6 months, the curves start to separate, and that persists largely for the duration of the trial. And the number needed to treat for death alone was 32. So very comparable to the numbers needed to treat that we saw for many of the other fundamental therapies used for the treatment of heart failure. Now, there were some other outcomes that were specifically measured in this trial. So LCZ 696 also improved death from any cause and the change in Kansas City cardiomyopathy questionnaire. But there were no differences in new onset atrial fibrillation, nor were there any differences in decline in renal function. And I specifically point out renal function based on some differences that we'll see in a few moments in some of the lab abnormalities between the two groups, but there was no difference in decline in renal function. So when it came to the safety endpoints, as you might expect, the most common adverse effect was symptomatic hypotension, which largely drove the differences in the LCZ 696 group. You can see there when it came to a systolic blood pressure less than 90, it was about double the rate that was seen in the enalapril population, about 5% increase when you looked at symptomatic hypotension by itself. There were some differences in serum creatinine. The increases were greater in the enalapril group, but recall from the previous slide that when it came to overall decline in renal function, there was no difference between the two groups. There were differences in serum potassium between the two groups, at least as it related to severe hyperkalemia, which is higher in the enalapril group. You can see there 5.6% versus 4.3%. And lastly, when it came to differences in sort of bradykinin-mediated adverse effects, there was a greater number of patients who experienced cough in the enalapril group, but there was no difference in the rate of angioedema. But when you look here at the rates, this was very low. So it's very difficult to say whether it's truly a non-significant difference between the two, or just that the rates were so low to be able to show whether or not there's a difference between the two groups. And again, I'll come back to that in a little bit later. When you look at overall discontinuations, it did appear that LCZ 696 was better tolerated than enalapril, and actually fewer had to stop the drug because of adverse effects, about a 2% or so difference that was in favor of the LCZ 696 group. Now, as is the case with sort of any of these large landmark trials, there have been a number of follow-up analyses looking at specific subgroups or specific outcomes of the trial. So a trial looking at, or a subgroup looking at the progression of heart failure showed that LCZ 696 reduced the progression, heart failure progression compared to enalapril. Now, interestingly, when you look at the mode of death that drove the differences in cardiovascular death in the study, it was sudden cardiac death. Now, recall that one of the major risk to generalizability of this trial was the fact that only about 15% of patients had an implantable cardioverter defibrillator, which we know ICDs reduce the risk of sudden cardiac death. And given the fact that this was the primary driver of the differences in death with LCZ 696, it really sort of calls into question whether you would have seen such a compelling difference in death if an appropriate number of patients had had an ICD. And then finally, when you break down the patient population by age, the benefits with LCZ 696 are really seen across the board. Now that we've covered the trial in detail, I want to talk a little bit about some of the remaining controversies as it relates to the use of this drug therapy, which is now approved here in the U.S. So the first of which is the fact that many of the patients in this trial were on suboptimal background therapy, both in terms of the fairly low rates of aldosterone antagonists, despite the fact that many patients would have been eligible for one, and more importantly, as I touched on the last slide, the fact that so few patients had an implantable cardioverter defibrillator. I think there also needs to be some additional data looking at specific subpopulations, and probably the most important of which are Black patients. So as I mentioned before, only about 5% of patients in the trial were Black, and this is important for a couple of reasons. So one, we know that Black patients have traditionally responded less favorably to a number of therapies in chronic heart failure, including ACE inhibitors, beta blockers, and aldosterone antagonists. It's really the nitrates and hydralazine that have shown the most compelling benefits in this subgroup. Also, the second issue is that we know that Black patients are at an increased risk of angioedema, and with that being an adverse effect that we are especially sensitive of because of the rate seen with omapatrilat, I think it really needs to be studied in a larger population to see, is there truly a difference in angioedema rates among Black patients who are receiving the neprilysin inhibitor ARB combo. And lastly, so few patients with class 4 and no patients with class 1 were enrolled in the study, and then those with acute decompensated heart failure. And we really don't know the effects of LCZ 696 in those populations. So the patients in this study had to have been on an ACE or an ARB plus a beta blocker for 4 weeks or longer. We really don't know what benefit there is in the treatment-naive population. Although there were differences in the impact in blood pressure, traditionally trials do not pick up the rates that are seen in sort of a real-world population. So I know a number of heart failure patients have issues with blood pressure, particularly as the disease is more advanced. So it will be interesting to see what the impact of blood pressure of this new agent will be in sort of the real-world population. The fact that neprilysin inhibitors affect pro-BNP and NT-proBNP will be interesting to see, how this potentially influences how we use those serum values for monitoring of patients, particularly with heart failure exacerbations. And then finally, what are the off-target effects of neprilysin inhibition? There's been some suggestion that perhaps it could increase the risk of Alzheimer's disease, perhaps cancer, although none of those signals have been seen in clinical trials. That's really the thing that has to be picked up in post-marketing surveillance. So more to come for a number of these. Now, sort of the other drawback for this study is that I've sort of listed here on this table the accumulated evidence that we have for ACE inhibitors and ARBs. This is both for symptomatic heart failure as well as asymptomatic left ventricular dysfunction. We know across a variety of patient populations that we have a benefit with ACEs and ARBs, and you sort of pair that up to the single paradigm HF trial, and I think we still before we start converting patients over in a widespread fashion, I think some additional studies would be helpful. So where should sacubitril valsartan kind of fall in our current treatment paradigm? So this is completely speculating, sort of based on the data to date. Now, because patients were not required to be on aldosterone antagonist or nitrates and hydralazine, then I really think that this will be an option to perhaps switch patients to sacubitril valsartan in the early period. Now, I've listed this as a class 1 recommendation. I think it will be listed as class 1 because there were benefits over ACEs and ARBs, but because there's only one trial to show that so far, I think the highest it could be is a level of evidence B at this point. But in terms of my personal practice, I think that because the background therapy is really suboptimal, and given that sort of there's going to be limitations with tolerating the blood pressure effects, certainly the cost associated with this new medicine, I think that probably where I will see it most is those patients who are already on optimal background therapy but continue to be poorly controlled. So, for example, those that continue to be hospitalized, those that, as you look at their BNP, they appear to be uncontrolled from a neurohormonal standpoint. I think those are those patients in whom switching to sacubitril valsartan will probably benefit the most. So if you have a patient that comes in on sacubitril valsartan, or you start a patient on it yourself, I want to briefly go over some of the practical aspects. So first, despite the fact that the study was primarily class 2 and 3 patients, the drug is approved for class 2 through 4 heart failure patients. Again, this is reduced ejection fraction. There's an ongoing study to look at the preserved EF population. Many of the contraindications are very similar to what we see with ACE inhibitors or ARBs. So, of course, hypersensitivity to either component of the drug. But patients who've had a history of angioedema related to previous ACE or ARBs, because there's a very similar risk with this drug therapy, you would avoid it in that population. Because of the known risk of angioedema with combined neprilysin inhibitor and ACE inhibitor use, patients who are being switched from an ACE to this combination should undergo about a 36-hour washout period to safely make that transition. And then because of a separate trial looking at the drug used in combination with a variety of other agents, those that are on aliskiren and have diabetes are at increased risk for adverse effects. So that's also a contraindication. So when it comes to dosing the therapy, so the drug is listed by its individual components. So although in the trial it was listed as being 100 milligrams twice daily, the way it's listed in the labeling is by the individual components. So here you see 49/51 milligrams twice daily, essentially 100 milligrams twice daily. So for that population that was enrolled in the trial, that is those that were on ACE inhibitors equivalent to enalapril greater than 10 milligrams per day, or an ARB equivalent to valsartan, you can start at the initial dose that was studied in the trial and then titrate to the goal dose of 200 milligrams, a total of 200 milligrams twice daily. Now, interestingly, the drug was approved in a variety of populations that have not yet been studied, and so there are some differences in the dose recommendations in those populations. So first, for those naive patients, so those that have not been on ACE inhibitor or ARB in the past, again, not a patient population that was studied in Paradigm, or those that are on lower doses of ACE inhibitors or ARBs, again, people who have not made it through the run-in phase of this trial, then you would start at half the starting dose. So essentially a total of 50 milligrams twice daily. For patients who have severe renal impairment, so a GFR less than 30, again, not a population that's been studied yet, you would start at half the dose. And for those with moderate hepatic impairment, you also start at half the initial dose, the 24/26 milligrams twice daily. Now, when it comes to titrating this drug, it's a little bit slower than what's traditionally used with ACEs and ARBs. It's more like the titration schedule that you might use for a beta blocker, likely due to the potential risk for hypotension with this therapy. So you would double the dose every 2 to 4 weeks as tolerated to attempt to get patients on a total of 200 milligrams twice daily, or listed here by the individual components, 97/103 milligrams twice daily. Now, in terms of precautions and drug-drug interactions, many of the precautions are very similar to ACE inhibitors. You can see here, because of the ARB component, pregnancy and breastfeeding should be avoided. Many of the adverse effects listed here are very similar to those that we've covered earlier. From a drug-drug interaction standpoint, as you might expect, other RAS inhibitors, including potassium-sparing diuretics, you have to be careful with the potential risk of renal impairment and hyperkalemia. NSAIDs, because of the ARB component. It can increase lithium concentrations in the blood. And fortunately, there's very minimal cytochrome P450 involvement, so not a risk of interacting with those drugs. But this combination has been shown to inhibit organic ion transport proteins, specifically 1B1 and 1B3, although it's not known what the effects of that interaction are clinically. So that concludes my presentation on sacubitril/valsartan, and I appreciate your attention.